Operators here, nothing to be asked directly to
A
the
57-year-old
people.
male, MRD number 272063, diagnosed with grade 3 hemorrhoids at 11 o'clock, with the complaints of something coming out per rectum since 6 months with pain during defecation. On examination, grade 3 hemorrhoids at 11 o'clock and grade 2 at 3 and 7 o'clock. On investigations, all reports within normal limits. The surgery is to be performed by Dr. Kamal Gupta.
Yeah, good morning, everybody. Are we with you? Prayesh, am I
Yes,
with
Kamal, we can hear you.
Okay.
What are you planning for this patient?
Yeah, Pravesh sir, very good morning to you. Pravesh sir, the patient has got grade 2 hemorrhoids at 3 and 7 o'clock and grade 3 at 11 o'clock. So what I propose, I will like to go for finger-guided hemorrhoidal artery ligation with laser hemorrhoidoplasty at all the 3 places, and in case it is required, at 11 o'clock, I will go for rectoanal repair or Blaisdell. That is mucopexy or Blaisdell. And as Prayesh has pointed out, I will be just, narrating all the steps, but I will not be answering any questions. I have got a moderator with me. Dr. Maheshwari is there. So all the questions can be directed to him. And once I finish the case, only after that I will start answering the questions.
Okay.
So this is the first step. This is Park's maneuver. Now you take 3 gauze pieces, roll them, and take them inside. Gradually bring them outside to assess the degree of hemorrhoids or the degree of prolapse. So you can make out the mucosa prolapse is there at 11 o'clock position.
Yeah, we can see that 11 o'clock pile prolapse.
Yeah, so that is there. So I will take a half-cut proctoscope. Jelly, please. Alice. 20 Vicryl. ये पकड़ना पड़ेगा किसी को ना आप आगे आ जाइए प्लीज.
Kamal, you can just talk a little about your finger guided ligation that you are doing.
Yes, so that is what I'm going to start. So the first step which I'm going to do is palpate the vessels. Now these are the pile masses, and one thing I would like to share with the audience, that never expect the hemorrhoidal artery branch is going to be at 3 o'clock, because the position of the rectal arteries is not constant. So I am just palpating. It is there. It is around please आराम से छोड़ दीजिए इसको ना, आप पकड़िए. It is around 2.5 o'clock position, not 3 o'clock. So I will take a stitch now. So the thread which I am using is this is 26 mm 5/8 needle. So normally I use 27. And just this is a dentate line. I want everybody to appreciate the dentate line. This is a dentate line. And
no, your head is coming in the way. If the cameraman can just go to the side. He can shift to your left actually.
Yeah, I think cameraman is adjusting.
Yeah.
थोड़ा सा ना
So
अंदर
which
light
suture
आ
do
रही है
you use,
please.
Kamal? Which suture you said you use?
Light is not inside actually.
Yeah. Probably if there's a cord light, it can show inside. So can you describe at what level are you going to take this suture?
Sir, I will be taking a stitch 2 to 4 centimeter above the dentate line.
Okay. 2 to 4 centimeter proximal to the dentate line. And what number vicryl is this?
So the whole purpose is to go 2 to 4 centimeter above the dentate line, is that once you are 2 to 4 centimeter above that, the depth of the vessels is 3 to 5 millimeter, and it is very easy to palpate the vessel and take a bite. थोड़ा सा ऊपर करके रखिए please, ऐसे ना, ऐसे.
So you're taking a bite in the submucosa, right?
No, I am taking mucosa, submucosa, and the fibers of the internal anal sphincter. Give me another.
So your needle is going through the internal sphincter.
And Professor, I will not be able to answer all the questions as per NMC guidelines, but definitely I can demonstrate.
So, Dr. Maheshwari can answer that question.
Dr. Maheshwari, you can answer on my behalf. I am taking the stitch that is थोड़ा सा इसको ना खींच के ठीक कर लो आप इसको पकड़ लीजिए 2 to 4 centimeter above, taking mucosa, submucosa, and this is a figure of 8 stitch which I am taking. This is based on vascular surgery principle. If you want to occlude a vessel, the surrounding tissue should always be taken. So all of us as surgeons are very well aware of that. And I always use 2 needle holders. Where is my needle now? Just hold it. So that is a figure of 8 stitch. Now I will ask my assistant to go for milking. इसको ना ऐसे ऐसे press कीजिए, नहीं आप कीजिए. So this will lead to disengorgement, and then I will take a knot. छोड़ दीजिए please. Now once I have taken a knot, again I would like to palpate. Now I am not able to palpate. It means I have taken a stitch deep enough to encircle the vessel.
How do you compare DGHAL with finger guided ligation?
Doppler guided, actually FG Hall is based on the principle of DG Hall, because when somebody taught me how to do internal opening on DRE, how to find it, so next thing which clicked was, can I replace Doppler guided with FG Hall? If my finger can find internal opening, why can't I palpate the vessels? And since last, I think almost 10 years now, the results are at par. Now there are nice guidelines which have very clearly demonstrated that.
As I understand, you are going to ligate all the vessels first and then you will do the laser.
Yes, sir. The principle is.
So can we go in the meantime audio to Pradeep's side? I think he's waiting for the next step. We'll come back to you, Kamal.
So
can
this
we
is
shift the audio
additional,
to Dr. Pradeep Sharma?
This is the additional vessel which is palpable at around 6 o'clock. And it's a wrong notion to say there are only 3 vessels.
So basically, whatever pulsations you are feeling, you're going to ligate those vessels.
Yeah, I will be ligating all the
that
vessels, but I will not be doing laser hemorrhoidoplasty at these places. Laser I will do only at the places where hemorrhoids are present.
Okay. Fine. Can we go to Pradeep? Can we go to the other OT, please? The audio. Can we shift the audio to the other OT?
Please shift the audio to OT1.
Gauze piece, please. खोल के दे दिया.
Is there somebody there from the audiovisual side listening? Audio बीजा OT ऊपर shift करो.
इसको ठीक क्लियर कर लीजिए. इसको छोड़ दीजिए, please.
Please shift the audio to OT1. The technical staff.
Now it is
Pradeep sir,
shifted.
you're audible to
Pradeep,
the hall.
Now we are with you.
Hello. Hello.
Yes, Dr. Pradeep, you are
Yeah.
online.
So what I have done after I have done a Gibbs procedure or a punch excision, I have irrigated the wound. Okay. Now I am going to put the fiber and I am going to ablate this tract. It is roughly 3.5 centimeter. I have already measured. So I am going to maximum deliver 350 joules. Okay. So in this case, the fiber is going in very easily, as you can see. इस तरफ आ जाइए. मुझे वो screen देखने दीजिए. हाँ. Yeah.
We can see
So
that.
you can see that the fiber is going in very easily. But suppose sometime the fiber doesn't go very easily, I'll show you one trick how to do that. You first put the probe inside. Over the probe you can railroad the tip of an infant feeding tube, bring it out like this, and then you can railroad the laser fiber on this. Okay, got it? Hello?
Yeah, we're listening.
Yeah.
We got it.
So now I am going to ablate the tract. Okay, and this is a radial fiber. this is a new fiber, what is called as a corona infinite fiber. Okay. So camera ki taraf bataiye, corona infinite ring fiber. So if you can see that we have the corona fiber, we have the radial fiber where there is one ring, corona fiber has 2 rings, and now this new corona fiber has got 4 rings. What does that mean? That means that at 4 circles or 4 levels the laser energy would be delivered. So what is the advantage of that? The advantage is that the amount of skip areas which is left behind after a laser ablation will be on the lesser side. So now I am going to ablate the track. So I have kept the setting as 10 watts. I always use a continuous mode because again that is in an attempt to avoid a skip areas, and I am going to keep a watch on how much energy I am delivering. So my eyes would be on the machine. So I always keep the machine in front of me. Never keep the machine behind you. It should always be in front of you so that you can yourself keep a watch on the amount of energy delivered. Everybody should use a safety goggles, and once everything is ready, we put the machine on, put the machine on ready mode. So once he has put the machine on ready mode, I am going to release the lock on the foot pad, and now I am going to start delivering the energy. Keep a suction over here because fumes would come out from here. Keep the ice water ready. Okay, so now I am going to start delivering the energy. Okay. So we have gone up to 50. So go on moving the fiber. The fiber should not be stationary at any point. So how much we have delivered? 255. Okay, so it is well within the limits. Okay, it is not necessary that if it is 350 you have to deliver 350 only. It all depends on you. You try to, from your side, you try to ablate it well. Now there will be always an SR accumulation on the tip. So sister, take a piece of wet gauze with little hydrogen peroxide and clean it, and give me a scoop. I am going to now scrape this track. Now why do we scrape the track? Because we have burned the tissue. When you burn the tissue and SR is formed, this SR has to come out because this is a dead tissue. So whatever epithelialized tract, abscess cavity which I have burned, I am going to scrape it out. Sister, give me little saline also. I am going to flush it. Normal saline. No, cold saline, sorry, now cold saline. Okay, so now we are putting cold saline inside, so this will help to cool the tissue also. Scrape it. So this has to be scraped in all 360 direction in a circular manner.
Pradeep, earlier there was a question from the audio, somebody from Gangaram Hospital who said that they use a cautery instead of laser. You think that makes a difference?
Yeah, you can use a ball cautery, but you require you cannot use a normal cautery.
No, scope, with a scope, they cauterize
yes,
the...
Yeah, with the WAF scope, you can use a ball cautery. Ball cautery is better than a normal cautery. Have you cleaned the fiber?
So are the results different compared to laser?
I don't know. I don't have much experience with it, with the ball cautery. But I think it should work. It should work because probably... See, our aim is to ablate the tissue, whether you ablate it with radio frequency, you ablate with laser, you ablate with cautery or any other energy mode. I don't think so it should make much of a difference. I think it should be the same. So now we are going to...
Yeah, you can ask.
Ablate again. Again put it on ready mode. It's ready. Haan, theek hai. So I have 100, I can deliver 100 joules more.
Take the mic, please.
So earlier I had delivered 250. So I have about 100 joules more in my kitty. So I am going to use that 100 joules now for the second sitting. Okay. So everything ready? Yeah.
Is the mic working there?
Please kindly shift the audio to OT number 2.
How much?
So while Pradeep, while you fire this, we'll just go to the other OT. Okay.
Sir, what I was mentioning was for the ball, there is a ball cut tip which
Professor, am I with you?
That's what he said. That's what he said.
with spray setting. It works very well. You have to put it like
Array, curiosity look is very important.
skip lesions are very less. In laser, we are not sure it's not the vision for doing the laser, so you have to recheck with the scope after you have put the laser and bring.
No, but take now.
So we are back with you, Kamal, now. As we saw, you have ligated all the vessels that you could feel.
Yeah,
of the
Professor, am I with you now?
Yeah, I'm with you. Can you hear me, Kamal?
Yes, sir. Sir,
So
I
as
have
we
done all
saw,
the ligations all
you
around.
ligating all the vessels.
All the
Whatever you
ligations.
pressed, you
Now
have
I'm
ligated.
again going to insert 3 gauze pieces and gently bring them out. Now previously, if you remember, we had shown how the masses were coming out. Now there is no mucosal prolapse.
Okay.
So
So
that
you
is,
ligated the 11 o'clock hemorrhoids.
yes, sir. All the 3 hemorrhoids plus additional ligation at 6 o'clock has been done. So now I will start with the laser hemorrhoidoplasty. Now whosoever is standing in the OT should be wearing the goggles. And I have got 2 fibers with me. One is a bare fiber and another is a conical. Both are good enough to be used. So the dosage is 6 watts. ये मेरी वाली स्पेक्स उतार लो आप पहले मेरी वाली उतार दो आराम से दोनों हाथों से
Hello, sir. Sir, my name is Sukhdeep Singh from Punjab. Can I say, can we use fixation procedure like fistula in this type of short PNS?
So I think he has done that. He did that. He cored out that track
IM?
with that fixation device. He did that. So basically that
इसका नाम क्या
even
है?
that punch biopsy does that only.
Machine
It
का
cores
नाम
out the
क्या है?
track. But you could use it. Provided
IMD,
if you have a
IMD.
thin track, then you should have a thin size. The punch biopsy has got different sizes, so you have to adjust the size.
IMDSL.
Fixation device must be just one size. So if it's
L
a
is
small
less.
track, that may be too big also.
So now I'm going to go for laser hemorrhoidoplasty and the equipment
Yeah.
is 1470, not 980, and it is from IMSDL, IMDSL, and the dosage which I have fixed is 6 watts, 3-second pulse because it's a new fiber. But had it been an old fiber, I would have increased the intensity because with multiple uses, what happens, the intensity of the power goes down. So this is a bare fiber. And I have got a foot switch which is Bluetooth activated. Now this is a mucocutaneous junction. This is a white line of Hilton. This is that is the dentate line. This is a white line of Hilton, and I am entering from
Your head
here.
is coming on the way, Kamal.
Yeah,
Your head is coming on the way. Yeah, now you can see.
okay.
So you're
this is-
puncturing at the mucocutaneous
Can you
junction.
switch off the light at my back? Please switch off the light.
The focus is gone. Can you just...
लाइट्स पीछे से बंद कीजिए सर नाउ दिस इज व्हाट आई वांटेड टू डेमोंस्ट्रेट नाउ दिस इज अ
We can see the light inside.
so this is the ideal position. I am parallel to the anal cushion and now I am going to activate automatically the tip of the fiber stops at a distal end where ligation has been done. And
You're firing the...
there is automatically cut off by the equipment because it is fixed at 6 watt 3-second pulse and 18 joules they are given, and this is the fourth one. So I have given just 72 joules over here, and lights on please. Light on. Yeah, just छोड़ दीजिए please इसको ना. So now going to the second one. थोड़ा सा क्लीन करके रखिए साथ साथ ना. इसको पकड़िए प्लीज. every time you come out, make sure the tip is intact, and secondly, you are supposed to clean it with a wet gauze. मेरे को saline gauze दीजिए.
Kamal, how many times can
This
you
is
use
very
this fiber?
important. Otherwise, carbonization is going to be there at the tip, which will reduce the energy emission by 45%. So
How
this
many
is,
times can you use this fiber?
sir, maybe 100 times. Many things depends upon. थोड़ा सा लगाइए. Many times things depend upon how our staff takes care of the fibers, and everybody should be well trained. Clean कीजिए ना, तो गंदा क्यों फील मेरा? Clean it. There should not be any blood. छोटा लीजिए ना gauze piece. So bare fiber can be used repeatedly. ये
Sir.
नहीं जा रहा.
Sir, one question.
Yeah. Before starting of the laser, means at the initial time, the bare fiber were using for the piles, and then again conical is in a trend, or in conference we used to learn that. Now again this is using bare fiber, so which is the right fiber to use?
I have got both the fibers with me, conical as well as bare. There is nothing called a trend. It is the laser equipment companies which start all this trend. And when I started doing lasers, for many, many years I used conical. But every time students used to ask me, even when I used to go to IMAS to teach, can we use bare fiber? Since I had not used at that time, lights on kijiye please. I always used to answer that I am not sure. But then I came back, I started using, now I use only the bare fiber. And when I go to many conferences and this question is being raised, and many people say they are using bare fiber only with good results. And I think it's more of a marketing conical versus that, because behind every fiber is a bare fiber. It is just a tip which they are attaching, in a conical way or a radial way. Radial I still understand. Radial means it is good for, Alice please. Radial I still understand, it is good for, थोड़ा सा ऊपर वो लगा हुआ है.
Sir, after application of laser, is there any need for a cold
ice finger है?
application
Ice finger रखी है आपने?
to prevent the latent
ठीक है,
damage?
रखी है.
Because it's not applying anything to cool out the local tissue as far as the damage of the mucosa is concerned.
It's okay now.
Nice.
Bare fiber,
Kamal, there's a question that would you use ice after every laser firing, or you want to use it at the end?
Sir, I will use ice pack at the end. I have tried everything. People used to say you keep on giving cold saline after every this thing, but there is something called TRT, that is thermal relaxation time. That means the energy which is dissipated in how much time? It is nanoseconds in which 66% of the heat is dissipated. So see, my fiber is intact. Now give me some gauze piece. So it really doesn't matter. It is all hypothetical things, but if you read in depth about the laser beam, the latent heat, then one realizes that all these things are possible. Even if you keep a finger, ice finger, after end of the procedure, it's not going to make much of a difference. So this is some bleeding which is coming at the entry point. Now this is something which everybody who is watching this live video should know, that this is one of this is something which can happen at the time of surgery, where the point of entry is there, because there is the vessels are present. Although we always say above the dentate line it's the superior hemorrhoidal artery, below the dentate line it's inferior, but there are present anastomosis between the two, and this is a place from where the bleeding can be there.
So Kamal, you're recommending that the ice, you don't have to use the ice pack after every pile that you laser.
So I do keep ice finger at the end of a procedure. मेरे को jelly दीजिए ना, थोड़ा सा वो
the
दीजिए
end of the
सब में
procedure. Yeah, what is your
एनोमेट्रोजेल
question?
पड़ा होगा कोई एनिसोक्राल फेट मेट्रोजेल एंड लिग्नोकेन ऑइंटमेंट
Of use cold finger at the end. How does it?
Any ointment will
work
do.
At the end. At the end of the procedure, how does it work?
So the Kamal, the question is, if you're going to use the ice finger at the end of the all the piles, then how is it going to help?
Sir, honestly, there is whatever I have learned is based on literature. So initially, as I told you, people used to say, you give saline, different suggestions started coming, and I started listening to everybody. But then finally I thought, even if I keep it for 8 to 10 minutes, initially I used to keep it for almost 15 to 20 minutes. Then I happened to read one publication from Philadelphia, betadine please, from Philadelphia, where it was mentioned, in case you keep ice more than 8 to 10 minutes, chances of crystallization are much higher. Crystallization in the capillaries. So it can give a condition like frostbite. So after that, यार इसको ना अच्छी तरह करके दो, ऐसे बना के दो ना, मुझे clean करना है.
Parvez, also can you ask if he uses Hylace for big piles?
Yeah, definitely. Always. Hylace, I read so many years ago in Corman, and then I read about the principle. And Hylace has got two uses. As far as the pile masses are concerned, now what can happen? There is marked regression. Why? Because it increases the tissue permeability. Now, secondly, if you are giving a pudendal nerve block, then in case you mix it with the Hylace, 1 ml, it increases the diffusion. Now, that was a principle which was taught to me by one of the leading most ophthalmologists of this country. And I asked him, why people say you people use a lot of Hylace in your ophthalmology practice. The answer I got was, it increases diffusion. Then I happened to read Goodman-Gilman because I wanted to be very sure. मेरे को bupropion दीजिए, bupropion.
Kamal, why did you apply betadine?
Sir, I am going to give pudendal nerve block. This is the ischial tuberosity, outer margin. I am going to release 10 ml on each side. This is to block the inferior rectal branches of the pudendal nerve. Now, this is a technique I picked up from St. Mark's. 0.25% bupropion they used to give post-operatively in all cases. Then I thought the patient is already under spinal. What is going to be effective? Then literature, it was very clearly mentioned, the effect lasts for 6.7 hours. Then I thought it is better to give instead of using post-operative, analgesics, it's better to give pudendal nerve block. So since I am giving since last 4 years, all my cases after surgery, I give pudendal nerve block. So I use betadine just to clean the perianal area and release the solution. So one precaution, every time you inject, make sure you have not injured the vessel.
Another question about the fiber is, if we are using the bare fiber, then the beam light is straight, and if we are using the conical, then it is wide angle of the laser energy. So it's not better that we use that conical one.
Sir, you can use anything. To be very honest with you, I have done thousands of cases with conical and thousands of cases with bare. No difference in the results. It's only in the mind. And इसको ना अंदर थोड़ा सा करके रखो please.
Is there any role for surface laser? Do we have any published papers to suggest whether conical is better or any
Sir,
the bare is better?
Why to talk about papers when I have written 5 books on the same subject? It's better to refer to the
we're already
books.
running late, so
Thank you.
as he says,
Sir, last question to you, sir. You have treated so many cases of Dr. Parvez, sir. I have a question for you. You are treating so many cases of complication of the laser in form of abscess and fistulas. So what you find the common factor or which most common factor for this complication?
Question is similar. That would to Dr. Kamal, of course. would he recommend withdrawing the fiber a little after it touches the stitch and the FGR stitch? Because sometimes it may puncture the mucosa and give rise to an abscess.
No, I could not understand your question.
So
I was
he
just
says,
moving from my chair.
there's
Now
one
I can
question which
answer.
I will answer Bhavin's question.
Now I can
He wants to
answer all
know-
the questions, sir. Now I have finished the case. I can answer all the
because
questions.
we need to move. Yeah, you can answer. Bhavin was asking whether how to avoid complications after lasers, especially like we see.
So how to avoid complications? Sir, the most important thing is complications can occur in any case without any warning. But if you are giving more energy, you think the pile masses have not reduced, you keep on giving energy. That is one complication which can cause. Lot of edema is going to be there. Secondly, in case you happen to, give more energy, there may be some tissue necrosis. So I have seen. So please hold on. I'm still on the audio. Please hold on.
I think we are already running late.
Yes, sir. So I will come to the hall and answer a question. Okay.